All right, well, welcome everybody. Today we are going to talk about using the ASAM framework for co-occurring disorders. This is a huge topic, and I could probably spend an entire week talking about all the elements associated with treating co-occurring disorders and all of the theories and practices associated with the ASAM criteria. So this is a lot to fit in a very small amount of time. So we're going to really go over the basics behind ASAM and talk our way through a couple of examples of how to assess and rate people using the ASAM framework. So hopefully we will get through it all today. Let me see. All right, so my background at MinCam, we've been here about 5 years, and I started out as an LADC in the field and went on to get my master's degree in integrated behavioral health. So I am really passionate about working with people who have complex comorbidities. So folks who are experiencing serious mental illness, in addition to substance use disorders, and often people have mental or physical health issues as well. So this is my passion. I also enjoy taking clinical research and bringing it to practice. So my background is really connected to this comorbidity aspect of care. So what is the ASAM? The ASAM stands for the American Society of Addiction Medicine, and they put out this publication, here's a little picture of the book, to help people work through the elements associated with treatment and placement and care planning. Originally, this started out mainly for people with substance use disorders and has evolved because co-occurring disorders are so prevalent. So we're now on our third edition of the ASAM criteria, and I heard they're working on number 4 right now. So what is it? It's a guide to help providers develop care plans and also to make objective decisions about placement along the continuum of care. So it's not just about initial assessment and treatment planning, but it can also help with discharges and referrals to other areas of care along the continuum. So one of the biggest questions that I have gotten about the ASAM criteria is that this is an assessment tool. But the ASAM criteria is not an assessment tool. It's really a framework for assessment and placement. There are assessment tools available that go along with the ASAM, but the ASAM in and of itself is really a framework or a system for assessment and planning. So just as a quick example, I'm going to share my screen really quick. The DAPR-3 is an actual validated assessment that goes along with the ASAM criteria. So if you are interested, you can go to eventsassessment.com and take a look at the information about the DAPR. You actually have to pay for this if you want to use it clinically, but it is available if you're interested. This was developed by the Change companies who are associated with putting out the ASAM book. So if you're interested, that's available online. So ASAM has 6 different dimensions for assessment and care planning. And these 6 dimensions really help us to get a holistic view of what that person's experience is. So it isn't just about whether a person is using or not using. We're really examining all elements of someone's life to help get a good idea of what we can do to help them move forward toward recovery. So Dimension 1 is acute intoxication and withdrawal. Dimension 2 is biomedical concerns. Dimension 3 is really about emotional and behavioral issues and complications. Dimension 4 is about readiness to change. 5 is about relapse, continued use or continued problem that people might have. And Dimension 6 is about the environment where people are trying to achieve recovery. So we'll get into those a little bit more. But there are a set of guiding principles that come with the ASAM criteria. And originally, treatment for people with substance use disorders was just about whether they were using or not using. And it didn't really consider very much aside from someone's use or not use. So really the goal was to help professionals out there in care move from this idea of using or not using toward this multidimensional. What is going on with someone in their life and how can we help them? Also, it helps us to avoid cookie cutter treatment. Many programs in the past have been standardized. So everyone, no matter what their issues are, would go through the same set of criteria and curriculum to get into treatment and then be discharged successfully from treatment. So the ASAM is really trying to help us move away from this program-driven treatment and really focus on what each individual needs for themselves. It also is allowing people to recover at their own pace. So we've all heard about the 28-day treatment treatment length of stay. And so, to some degree, this still exists, but the ASAM is really helping us to justify how long somebody needs to be in treatment to help them move toward recovery, because everyone recovers at their own pace. So many people need much more than 28 days in order to achieve lasting recovery. It also has helped us move from a limited level of care system to a much more broad continuum of care. So it's more than just inpatient versus outpatient. We have many levels all the way from prevention care to intensive medically monitored inpatient hospital-based care. So we have been able to provide more levels of treatment using these placement criteria. We're not going to talk a lot about placement today because that's a lot of information, but it is available if you have the ASAM book. There is information also in the ASAM book about adolescents specifically. Again, we're not going to cover that too much today, but if you're interested, that information is there. The goals of treatment are something that we have spent a lot of time talking about with folks at MinCam, and I'm sure that you have been involved in that somehow in the past, whether you've been to one of our trainings or whether you have participated in some of our webinars. We're very goal-based, and that's one of the things that we really love about the ASAM criteria is that it helps us to clarify what the goals are of treatment. And the rating in particular helps us to focus our attention on the areas of high risk so that we're not spending a lot of time on areas that maybe aren't so important to a person and that aren't causing as many problems in their life as the areas that are really at high risk or in need of immediate care. So also we're moving away from people who are discharged from a lower level of care in order to get into inpatient. So if people are at much higher risk, they will be able to be referred to care at a higher level using the criteria versus in the past when many people had to try to attend an outpatient program and fail before they were allowed into an inpatient based care program. This is helping us move towards a multidisciplinary, team-based care system. So this is really helpful for those of us who are focused on co-occurring disorders because we really want to be able to incorporate care for mental health as well as substance use disorders and even physical illnesses. So we are able to involve physicians in the process, nurses. We can either have therapists who are dually licensed to treat both mental health and substance use disorders, or counselors that can work very closely together to help someone move towards recovery. So, this team based idea is something that is particularly helpful for those of us that are working with people who have co occurring disorders. And we get to focus on treatment outcomes. So we can see very clearly, especially using the risk ratings, when people are improving or if people's risk are increasing. So we can tell how effective our interventions are using the risk rating system. So when we are conducting mental health evaluations, we often have biopsychosocial assessment perspective. And the ASAM is well designed to account for all of the elements of a biopsychosocial assessment. So many people think that the ASAM doesn't allow for sort of a traditional mental health assessment. Or a diagnostic assessment. But really, all of the elements that we use in a biopsychosocial can be accounted for in those 6 dimensions in the ASAM criteria. So everything from a spiritual history to treatment recommendations can be incorporated. Risk ratings can really help us standardize concepts that guide our placement and care. So when we're all using the same set of risk ratings, we can really follow someone's care over a period of time and tell whether or not people are getting better and potentially have some preventative interventions for folks who are having increasing risk. So this is an example of just general risk ratings in the ASAM framework. So a 0 would be someone who has no issue or very, very low risk, whereas a 4 is really severe. This is where someone is either in imminent danger or they have very, very difficult time functioning because of their symptoms or situation in that dimension.
Hey,
So,
Tanya,
yeah.
we had a question come in here from Katie who asked, what about the opposite situation? A patient who continually leaves residential treatment, AMA, and then coming back. Is there any information around how to work with these kinds of patients?
So people who have gone from residential care?
Yes.
Okay. Well, so the ASAM can really help us justify if someone is leaving treatment before they have sort of completed the program or shown a reduction in symptoms or risk, their risk is still high. And so oftentimes insurance has a difficult time engaging with people or allowing people to come back into that level of care. But the risk ratings really do help us to justify to insurance companies that that is the level of care that this person needs. So we really can't prevent people from coming and going in treatment, but the ratings help us with a standardized system of justifying the level of care that's needed. Sometimes folks like that would actually do better in an outpatient program for various reasons. And so if they are willing to engage in an outpatient program, then then that's the level of care that we want to go with because some treatment is better than no treatment. However, if they are appropriate for an inpatient care program, then we have risk ratings to help justify that to the insurance company. Does that answer your question, Katie? I don't see the chat here, Joe.
Katie says yes. Thank you, Tanya.
Okay, good. So, so our risk ratings here again are really helpful not only for ourselves to understand what's going on with someone and to help plan ahead or plan for what's going on with someone right now, but they can help people to account to third-party payers in order to have the resources that they need for where they are in their recovery. So I have tons of slides, so we're going to keep on rolling. So dimension 1 is about acute intoxication and withdrawal. And one of the biggest things that I have seen with folks who are working through the ASAM criteria is that they're not necessarily paying attention to that first word, acute. So when we are assessing for acute intoxication or withdrawal, we want to know what the risk is for that person's current level of intoxication or withdrawal. We don't care so much about what has happened in that person's history. We're not using that entire history of substance use to discuss the acute concerns. We're really focused on what's going on with that person that's sitting in front of us right now. There's one caveat to that, however. It's that if there is a history of severe withdrawal symptoms, if people who have experienced severe withdrawal have been to detox in the past, or have needed medical care because of withdrawal or intoxication, that part of that person's history is relevant in this dimension. And I know a lot of you in Minnesota who have used the Rule 25 assessment are used to collecting an entire history of a person's substance use in Dimension 1. I don't do that when I'm doing an assessment in Dimension 1. However, I am paying attention to their history of withdrawal or intoxication. And so the other thing that we want to consider when we are assessing for acute intoxication and withdrawal is that does this person need services? And the risk ratings are going to help us to do that. So are services needed to address their current intoxication or withdrawal situation? And for many people who are experiencing withdrawal and do need services, ambulatory withdrawal is a safe option versus going to detox. Many of us jump right into detox if someone's experiencing withdrawal, but often people are willing and able to receive medical care and remain in their home. So it really depends on the person and their willingness to manage their own withdrawal. Is it safe or not? And there are so many elements associated with withdrawal and a person's willingness to engage in medical care for withdrawal. But some of the most concerning issues are associated with people who are taking benzodiazepines or who are drinking very heavily. These are the two substances that can cause death for someone who is experiencing withdrawal. So if they have been using alcohol or benzodiazepines at all, we want to pay attention and start looking for these warning signs. They can stop or they can begin anywhere from 2 hours to 4 days after someone has stopped drinking. And we're really looking for headache or like a fast heart rate, someone who is sweaty or shaky. If anyone is experiencing nausea or vomiting, restlessness, someone who is really irritable or anxious, if they're disoriented at all or experiencing hallucinations, that can be an issue. That allows us to pay attention to the warning signs. And then if someone has experienced seizures in the past, that's a huge warning sign that they're likely to experience a seizure again in the future. So these are things to watch out for. Those are the
Tanya,
biggest dangers. Yep.
we had another question come in. Kathy asks, how would you assess someone who is on MAT and would be in withdrawal if not dosing daily?
How do you assess for that?
Yes, how would you assess someone who is on MAT and would be in
Mhm.
withdrawal if not dosing daily?
Okay, so we're talking about someone who is experiencing withdrawal from an opioid replacement therapy. I'm assuming is what you mean. And this often it's really uncomfortable for someone who is experiencing withdrawal from opioids or opioid replacements, but it's not those folks are not at risk of death. They are, however, at risk of using again. So if someone is experiencing some withdrawal because they're not taking their dose as needed or they're not taking it daily, then really the effort needs to be getting them back on that MAT, that opioid replacement therapy, um, rather than to help them manage the withdrawal because we don't want them to stop taking that. That's helping them with their recovery. However, what happens in Dimension 5 is their risk of relapse goes way up. So that's what we would want to pay attention to is to manage that risk of relapse and to help them understand that their withdrawal risk goes up, but the treatment for that is to continue to take the medication.
Okay, Kathy added someone who is not going through withdrawal because they're taking their dose, but would go through withdrawal if they stopped abruptly.
Can you say that again, the beginning part?
Sure, someone who is not going through withdrawal because they're taking their dose, but would go through withdrawal if they stopped abruptly.
I see. So if they are not going through withdrawal, then their risk rating is 0. They're not experiencing withdrawal right now. If they did stop, then their risk rating would go up. So this is all about acute. This is all about acute risk. And so if they are not experiencing that, then there's no risk in this area.
Okay, thank you, Tanya. Thank you for expanding on that, Kathy.
Yes, thank you. That was a really good question because we see this a lot too, is that history comes in, or we think about potential risk for withdrawal or intoxication. But really, we need to focus that risk rating on what is happening with that person right now. So forget about the future, forget about the past, but what's going on right now. If they do stop taking their meds or if they do start drinking, then we have acute intoxication risk. But if there's no use, no withdrawal, there's no risk. It would be like saying that um, someone who has a family history of diabetes is at a higher risk right now, or needs to have treatment right now, but really the risk is a future risk if someone is
Okay,
not having diabetes. Yeah.
so Tanya, there's another question from another Kathy. First one was Kathy with a K. This is Kathy with a C. How risky
Okay.
is the Xanax withdrawal?
Xanax. So Xanax is a benzodiazepine, and so it can be very, very risky. If they're on a high dose and they stop using abruptly, seizures could occur and death is a potential outcome. So any benzodiazepine or high levels of alcohol use put people at a very, very high risk. Those are the folks that really are going to need medical care. And if they're not willing or able to engage in ambulatory withdrawal, a hospital-based or a detox program is important.
Thank you, Tanya.
Thanks, Joe. I can't see all of the chat, so I'm glad you're interrupting me. So let's think about Sarah. Sarah is in care for anxiety and depression. That's why she came. She's really feeling down. She's used meth and cannabis heavily over the past 2 years, but she's not using meth right now. She just came off of her last binge use about a week ago. Um, she is still using cannabis. She's smoking weed regularly. She gets anxious in the morning, and so she smokes when she wakes up in the morning, and she's also smoking at night when she goes to sleep. And her risk rating is at a 0. And you probably have questions about that because she's using cannabis. And there are some withdrawal symptoms and intoxication symptoms that go along with cannabis. However, Um, the risk rating is 0 because she is able to function and she can cope with those symptoms. So if there are no signs, that leads to a risk rating of 0 if someone isn't using, or if it's something like someone who is using cannabis or marijuana regularly, but isn't putting themselves at risk and is able to manage their symptoms, the risk rating isn't high. She doesn't need any kind of services associated with withdrawal or intoxication management.
So Tanya,
Yeah.
another question that came in, and this may circle back to the how risky is the Xanax withdrawal question, but
Mm-hmm.
Tom asks, but do you need to be planful in making treatment recommendations if they are currently not in withdrawal, but will be once they discontinue use and make sure they can continue to obtain their MAT medications?
Yes, absolutely. So we would never want to refer someone who is already taking opioid replacement medications to a program that doesn't allow that. So that puts them at a higher risk for relapse, and this is one of the areas that we can focus on as we go through and get to Dimension 5. We can talk about that more. That's a necessity for someone um, to manage their cravings and their relapse potential. So we would never want us to refer someone to a program that doesn't have those elements. Good question. Well, let's think about Ron here for a moment. So Ron is a little bit different than Sarah. He got referred from corrections. He was under the influence and got into a fight when he was drinking. He drinks pretty heavily, usually more than 5 standard drinks per day. He says that he hasn't had anything to drink in the last 24 hours, and it seems like he's sweaty, shaky, and is having a difficult time engaging in a conversation. Sometimes he's able to, and sometimes he's having a hard time focusing. So this is a much higher risk. He's using alcohol, so that is one of our high risk um, substances, and we are observing some symptoms with him. He's also in that 2 hour to 4 day window where people are at highest risk when they discontinue drinking. So if we had information about his blood alcohol content, that would also help us to understand how much risk that he's in. Higher levels of blood alcohol um, are going to put someone at higher risk for withdrawal. So he's at a 3. He's going to need some medication management to stop drinking. And whether or not he's appropriate for ambulatory withdrawal, we'll find out as we go through the other dimensions. Dimension 2 is about biomedical concerns. So here we're really focused mostly on physical health. And this is strongly connected with mental health and substance use. It is in a different dimension because it's often forgotten and is often managed separately in care. So if you're in a hospital-based program, you're going to be getting care for physical illness, mental illness, and substance use disorders, usually with a multidisciplinary team. But many other mental health care and substance use disorder care clinics don't have the ability to provide physical health care. So we want to make sure that we're paying attention to it and accounting for any needs in this area in Dimension 2, even if we don't offer those services. So we want to think about current physical illnesses, and we also want to think about chronic illnesses that are going to interfere with a person's ability to engage in mental health or chemical health care, or are going to put them at higher risk for using um, or having a relapse of mental health symptoms. So we also want to think about communicable diseases. If someone is contagious and is going to put our population at risk, we should be paying attention to that. And also if a client is pregnant, this is particularly important for people who have opioid use disorders because because discontinuing use can cause harm to the fetus. And so we want to make sure that that there is a medical plan in place for clients who are pregnant and using opioids. So if we look at Sarah again and we think about her situation, we can see here that she has lower back pain. She's had it for a long time, almost 20 years. She has been prescribed pain meds in the past, but she doesn't really think that they help. Her pain has continued despite the use, and she hasn't taken pain medicine for a long time. She also says that she has been diagnosed with fibromyalgia and that it flares up occasionally. Um, she's not engaged in primary care right now, but she's open to getting um, care for her issues should they arise. So right now, Sarah's risk rating is 1 in this area. And she's not really at very high risk because she's got some chronic issues, but they're not creating any problems for her right now. We we can see that she has a good ability to cope with her pain, and that she is open to receiving care if she needs it. So this is pretty low risk. Ron's a little bit different. So in a regular assessment, if I were working with Ron and he needed withdrawal, I might start to make arrangements for, or withdrawal management, I might start to make arrangements for him to get that right away and discontinue the rest of the assessment, depending on how severe his symptoms are and how able he is to engage in the assessment. So if he's unable to engage in the assessment process and I don't feel like I'm getting valid information from him, then I might discontinue the interview and arrange for him to get withdrawal services right then and there. However, if he is able to continue, then I might continue on with the assessment and try to figure out what he needs beyond just management for his withdrawal. So in this situation, he says he doesn't have any medical problems. He smokes a lot, but he doesn't like doctors. He avoids going to the doctor at all costs. He can't even remember the last time he was at the doctor. Um, However, he does have a black eye, and his finger looks like it's broken because he was in this fight. But he says that the police didn't take him to the hospital. He didn't have any care for that. His finger is really red and quite crooked. It's clear that it is broken. So his risk rating is a little bit higher. Um, if he did receive medical care and his finger was set or was already healed, then it would probably be a lower risk, a 1 or a 0. But because he hasn't received medical care, his risk rating is at a 2 right now. If he had a more severe injury that was in need of care right now, and he was at a level 3 or a 4 of risk rating, that might also be a way or a reason to stop the interview with him and arrange for medical care. For example, if he had diabetes and he hadn't taken insulin for many days, he might be at very high risk, a level 4 risk, and that might require him to get medical care right away versus continuing the interview. Dimension 3 is really our bread and butter when it comes to assessment. So those of us in mental health care who are doing diagnostic assessments or psychological biopsychosocial assessments, the majority of our assessment takes place in Dimension 3. This is where we're focused on emotional, behavioral, cognitive conditions, and complications. So we want to think about psychological issues, cognitive issues. We also want to think about chronic illnesses. So this is where the mental health history comes into place, and that we're paying attention to what kind of care someone has received in the past. We also want to know if someone's mental health symptoms are interrelated to their substance use disorder. And so, this right here is why I conduct a substance use history in addition to a mental health history at the same time in Dimension 3 versus conducting a substance use history in Dimension 1, because these things are often so connected with people who have complex comorbidity that that it's impossible to tease them apart, and assessing them in separate dimensions for me doesn't make sense. So it is much, much more helpful to talk about these two sets of issues in conjunction with each other in this dimension for me. So this in blue is a comment that they make in the ASAM book about people who have mental illness symptoms that are separate from their addiction. And I haven't ever encountered someone with mental health issues separate from their addiction in my work. I don't know if any of you have, but I can't even think of a single client I've ever seen that has mental health issues separate from their substance use issues. They're connected. Um, So also, how severe are these issues? Um, how much care does someone need for their mental health? And is the place that we're referring or conducting treatment planning able to provide that care? So when we're thinking about co-occurring disorders, often people are getting care either in the mental health system or in the substance use system. And often there there are varying levels of care for the other side of the coin. And when we're doing referrals and treatment planning, we have to pay attention to whether or not that we have enough resources to provide care for both. So it's getting better out there, and our ability to provide high levels of mental health and substance use care at the same time are increasing. It's getting a lot better. So, how is that person able to cope with their symptoms, and are they able to manage their activities, or is their substance use or mental illness getting in the way? And there are these risk domains that ASAM wants us to pay attention to in Dimension 3 when we're thinking about risk rating. So, one of them is a danger to self or others. If someone is at high risk of hurting themselves or hurting others, then again, we're going to need a higher level of care. So if someone is really impulsive and the risk is immediate, then again, we want to get that person into a safe setting where they're safe and the people around them are safe. We may not want to continue the rest of the interview if we or that person are in danger. So that's
Okay.
one of the reasons why these dimensions are organized in this way, because we want to make sure that we are accounting for immediate needs kind of in this order. Go ahead, Joe.
Sure. So Diane has a question. Diane says, I'm required to conduct a mental health DA for residential admissions within 10 days. Can you
Yeah.
talk about making differential diagnosis and treatment planning?
Yes. So I think diagnosis is really challenging when people have a lot of things going on, and especially when they are first coming into care, if they are in withdrawal or even in post-acute withdrawal, and their mental health and substance use are so connected, it can be very, very challenging to understand what's going on with someone. And this is one of the really great things about ASAM, is that it allows us to paint a picture of what's happening for that person right now. When we first refer them to care, when they first come into care, but it also allows us to continue to use these criteria, these dimensions and ratings to assess what's going on with a person moving forward. So, in the first 10 days, we have a picture of what's happening with someone, but maybe 30 days into care, it has changed quite a bit. And so we're able to continue to monitor what's happening in all of these dimensions with someone, assign associated risk ratings, and then adjust care as needed. That's one of the things that I love about this risk rating and dimensional system is that all of this stuff carries forward and we're continuing to assess versus a lot of times in care, people get an assessment at the beginning, it moves into a treatment plan, and then the assessment is never looked at again unless something really bad happens, and then we drag the assessment out and do another one. This allows us to continually assess so that we don't have those issues where an assessment is out of date and we haven't really paid attention to some of the things that haven't made it onto the treatment plan.
Thank you.
Thank you. Good question. So we want to think about the connection again here, this risk domain and the interference with recovery efforts. So many people often talk about how substance use can increase mental health symptoms, but the flip side is also true. Substance use can be influenced by mental health symptoms as well. So we want to think about that. If we have someone who has bipolar disorder, and they become very manic, their likelihood of drinking more is going to go up. And so these things are quite connected with folks who have co-occurring disorders. And here we get to pay attention to it. This is another reason why I like to do my substance use assessment or substance use history and mental health history at the same time. Also, we want to know how much does their mental illness or substance use interfere with their relationships, because this is a part of the severity process, right? If someone is able to function and they're having symptoms, then obviously their coping strategies are working enough for them that their risk is lower than someone whose use or mental health is preventing them from being able to function in a social setting. Self-care is another one of those domains. Are they able to care for themselves, to provide themselves with food and shelter, or is their mental illness or substance use getting in the way of that? Oops. There we go. And so the course of illness obviously is important. If someone has a long history, then we want to pay attention to that and use that history to help inform their care moving forward. If someone has struggled with symptoms for a really long time and that's kind of their baseline, that's going to be a lower risk rating than someone who is highly unstable and is experiencing severe symptoms now that they've never experienced before. That's a higher risk because likely they don't have a lot of coping strategies to manage. So Sarah here these are some of her psychosocial issues. We're going to move forward because it's getting late in the webinar. She's struggling with depression most of the day, every day. She's having a hard time getting to work, but she is working. She wakes up anxious and on edge. That's why she's smoking weed in the morning. She's experienced these episodes since she was in middle school, so it's been a long time. She's tired all the time and she's having suicidal thoughts, but the immediacy is not there. She says she would not act on them. So she's really at a risk rating of 2 right now. If she were having if she had a plan or intent to act on those suicidal thoughts, her risk would go up. But right now, she does need mental health care. She is in need of some significant services in this area. However, she probably doesn't need immediate care. She doesn't need to go to a 24/7 inpatient unit. For her substance use, she started smoking weed at age 14. She drank when she was 15, but she doesn't drink a lot now, usually only when she uses meth. And her meth use started in her mid-20s, but she often uses after she's been feeling really bad and it doesn't go away. So she talks about her meth use in conjunction with these episodes of depression with anxiety. So you can see here that her risk rating um, is about the same for mental health and substance use. These two things are very connected for her. Um, and one of the things that you can do when you're working with co-occurring disorders is you can rate mental health and substance use separately. That can help us determine where to place somebody. If someone has a really high mental health risk, but a lower substance use risk, then maybe it's more appropriate to place them in a higher level of mental health care, but that also has the ability to address their substance use, and vice versa. If we look at Ron, and we see he has some psychosocial elements here, we're going to move through that quickly. He has no history of mental health care, reports no symptoms, but says that he has, his mood is low. He's not really a very joyful or engaged person. Um, he doesn't have any suicidal thoughts, but he gets really angry with his boss sometimes and fantasizes about killing him. But he also says that he needs his job and he would never act on that. He's not that stupid. He started drinking when he was in high school regularly and began drinking daily when he went to community college. He started drinking hard alcohol in his 30s when he was having problems with his marriage. And since his divorce, the last 3 years, he's been drinking at least 2 large glasses of whiskey and a 6 pack of beer per day. So right now, his risk rating, I have a 1 here. Um, and that's a typo. His risk rating for substance use is going to be a lot higher than his risk rating for mental health. So I would give him a 1 for mental health, and I would move him up a risk rating of 3 for his substance use because it has clearly created some significant impairments in his life. In Dimension 4, we're really focused on someone's readiness to change or someone's stages of change. So we want to know if they are aware that their substance use is creating a problem and how ready are they to engage in care. So if someone's stage of change is pre-contemplation and they're not ready at all, then they're going to score a lot higher in risk than someone who is aware that they have a problem and wants help. So we also want to think traditionally we're focused just on the substance use, but when we're working with co-occurring disorders, we also want to assess for someone's readiness to change regarding their mental health and their physical health. So we could have up to 3 different risk ratings for folks that are of mental health care, substance use care, and physical health care. So if we think about Sarah, she wants to get better and she thinks that she needs help. She's kind of skeptical about therapy because she's tried it in the past and it hasn't worked, but she really does want to stop using and smoking weed. Her family has encouraged her to do so. So she's really at a low level of risk for substance use in her readiness to change because she's pretty ready to change. For her mental illness, maybe a little less so. She's not quite there yet. She doesn't think that it's going to help her, but she's also not actively antagonistic. She understands that she has some problems with her mental health. Whereas Ron is just willing to do the assessment. He wants to get it over with. He doesn't believe in shrinks. He wants to get on with his life, and he says that if he's told he has to go to treatment, he would fight it in court. So these are pretty high risk ratings in both of these. He doesn't really understand how his emotional problems and his anger issues are causing problems in his life. He doesn't understand how they're connected with his substance use, and he doesn't think of his substance use as a problem at all. He's barely engaged. Dimension 5 is where we're really focused on relapse or problem potential. So a lot of that stuff that we're thinking about sometimes in Dimension 1, like what is the potential problem, this is actually where we want to focus on this. So if someone stops taking their opioid replacement therapy, then their risk of relapse goes way up, not only because they feel terrible because they're in withdrawal, but those cravings are going to start coming back, and they're much more likely to start using again. So relapse is not much more than just a return to use, though. We also want to think about relapse in relationship with someone's mental health. Has someone experienced a relapse of mental health symptoms? We want to think about immediate danger versus potential danger. Immediate danger of relapse is obviously going to be a higher risk than someone who has a future potential versus right now. We also want to think about, does that person have any coping skills that they can draw on from past care? Have medications helped in the past? How well are they able to manage their emotions and stress? So if someone is experiencing high levels of stress, they're much more likely to engage in substance use again, or their mental illness symptoms are much more likely to increase. So we really want to think about the context as well as the history of what's going on with that person right now. So how severe are they, and how likely are they to continue using? The higher the risk, the higher level of care. So Sarah here has had periods where she stopped using meth, um, but she doesn't have a lot of coping skills for her cannabis use, for her marijuana smoking. And she's never really been able to manage that depression and anxiety. She usually manages it by using meth. So she's at a pretty high risk for mental health relapse. And her skills for managing her substance use are a little bit better, at least for the meth, but still at high risk. So she's probably going to be able to manage to some degree and doesn't need an inpatient program, but she does need a fair amount of mental health services to help her get those mental health symptoms under control to keep her from relapsing. Ron has never tried to quit drinking. He's never received mental health care. He has no idea of what his symptoms are. He usually copes with stress by drinking, and so he is at a higher level of risk for relapse in substance use and mental illness. I'm keeping an eye on time right now, so we're going to move right into Dimension 6, which is someone's recovery environment. And this is the degree to which a person's environment is going to help them engage in care or prevent them from receiving care. So one of the things that we think about are these legal consequences, and sometimes that puts people's risk up higher because they're involved in legal situations. So Ron actually, if we think about Ron, his risk rating is at a 2 because all of his friends drink and he doesn't have a lot of positive support. But his legal involvement is actually a plus on this side because it's likely going to force him into engaging in some care. And even though he's in pre-contemplation stage of change, we'll be able to use motivational strategies with him to help him engage in care. Sarah is at a risk rating of 0 here because she has employment, she has housing, her family is encouraging and supporting her care, and she's not spending time with people who are using right now. If she started spending more time with folks that are using, then her risk rating would go up. Also, if she lost her job and her housing was at risk, her risk rating would go up. And the higher the risk rating, the more likely a person is in need of services. So if you're having a hard time understanding whether or not someone should be at a higher or lower risk rating, you can help answer that question um, by by understanding if someone is in need of services in that area. Do they need services to help them engage in social support? Do they need housing, transportation services? Do they have those services that are helping to keep their risk low and helping to support their recovery? So there are some limitations associated with ASAM for co-occurring disorders, and largely they come because the ASAM criteria was developed to help people with primary substance use disorders. It was adapted to include issues with co-occurring disorders, but really it's primarily focused for those of us that are providing care in a substance use disorder setting. And so, if you're in a setting that provides both mental health care and substance use disorder care, and you have some clients who don't have substance use disorders, then the ASAM criteria and the dimensions can be a little tricky to use with folks who don't have substance use issues. For example, Dimension 1 is not at all applicable to someone who doesn't have a substance use disorder. And for this reason, it's also not appropriate for young children. So if you have someone who's under 5, they're likely not going to be engaged in any substance use. And so Dimension 1 seems inappropriate for use with children. So if you're in one of those care settings, it can be kind of clunky to use the ASAM criteria, but not impossible. It can also be challenging to determine what dimensions to use when we're doing care planning. So often when we have risk in dimensions 3 and dimensions 5, it can be difficult to tell which dimension should I put treatment goals and care planning goals. And we have to use different ratings for substance use and mental illness within these dimensions rather than having a truly integrated rating system for whatever issue that person might be experiencing. So there are some challenges when we're trying to provide integrated care and use the ASAM criteria. If you have experienced them, you're not alone. And I'm actually working on something to try to provide a better framework for integrating care for those of us that have struggled. So stay tuned in the future. I might have another webinar on a framework for providing integrated care.
So Tanya, A,
Yeah.
I'm going to hold you that second webinar, and B, we have a couple of questions if you have time yet.
Yes, I do.
So the first one's from Lori, who asks, in Dimension 3, what level of risk rating constitutes hospitalization as opposed to co-occurring residential?
That's a really good question. So someone at a risk rating of 3 is probably going to need a moderate to high intensity of mental health services. So someone who is at a level 3 is appropriate probably for residential care where there is mental health staff available. I think you're referring to mental health versus someone who is having acute problems, someone who is actively psychotic and a danger to themselves, who will need more of a hospital-based program that's more intensive and provides more supervision. Same thing for substance use. If someone is experiencing really high levels and is at risk and is at a level 3 risk, they're going to need something that's moderately high in intensity, but maybe not the highest intensity. So someone who has a lot of stuff going on and is very high risk, and it is probably going to lead to them being injured or someone else being injured if they're not monitored, that's a 4. So that severe, those severe issues where someone's life is at risk are usually 4s, and those are the folks that um, are going to need more super, more intensive services.
Thank you, Tanya. And our final question is from Diane, who asks, does the number of failed treatments or repeat treatments indicate or justify high risk for relapse?
Yes. So, and it depends. So, if someone has been through care before and has relapsed in the past, that doesn't necessarily mean that their risk is higher. If they have come out of those experiences with coping skills that they have used, and they have had some success at at remaining abstinent or reducing their substance use, and they have brought those skills from previous treatments forward, then their risk is going to be lower than someone who has been engaged in care a lot of times but doesn't seem to have any coping strategies or awareness of the seriousness of their problem or ability to engage in coping strategies. So it really depends. If someone has gone through before and seems to have gained something from it, it doesn't mean that they're starting from scratch. They have some skills that they can build on, versus someone who has been through care a lot before but hasn't really had any sort of sustained growth after those experiences. That's a really good question.